Good morning, Dr. Ann Meli. How are you?
I'm very well, thank you. How are you, Akram?
I am excited. Let's say this is my first time in the IDS, so I'm very excited about it. How about
Mine
yourself?
too. It's my very first time here.
I see.
I'm very impressed by all of this.
Yeah, it's quite large, much larger
It's
than
so
I
large
expected.
you get lost here.
Yes,
I
right.
literally got lost on my way here.
Yeah. Luckily now they have apps for that. Like now you can at least try
Very
to
true.
find your way around.
Very true.
But yeah, is there anything you're interested in this version of the IDS? Like something that you want to
Yes,
check
I
out?
like looking at the demos and the workshops and seeing everybody, get their hands dirty on using stuff.
Yeah, talking about demos and hands-on, like I attended your lecture a little bit. You gave a little bit of a quick overview because you can't just put all the information in this little time. But about minimal invasive treatment of tooth wear. Can you talk to us a little bit? Can you share with us a little bit some information with the listeners of the podcast?
Yes, so that topic is combining how we treat tooth wear cases in the aesthetic zone. And what we're doing is we are referring to the European guidelines, which is what we should be following as a guideline. And injection molding technique does meet the guidelines on a number of areas, a number of points. It's additive, it's adjustable, it protects the underlying tooth. So we're giving priority to the protection of the underlying tooth over the success of the restoration itself, which means where in the past many dentists would focus on using materials that last long and they don't wear away and don't chip away and so on, but then you'd have to sacrifice a lot of tooth tissue. And we understand that tooth wear patients have already lost so much. We don't want to take away more of that. Plus, patients are living longer, thank God. I mean, we're enjoying our parents and grandparents for longer. So we need to keep our teeth for longer. And if we start damaging and being invasive, we are not left with much tooth tissue. And so at least if you can look at the guidelines and follow them, even if you do see complications like chipping of composite, you are still chipping away at the restoration. The underlying tooth is still there.
And it's manageable. You
If
can
you've
fix
used an additive technique, so it's just the underlying tooth of what the patient came to you. You only do minor adjustments like bevels. You don't hack away at teeth.
Nice. And about material selection, like for you, like you said, you like to use certain materials for this.
Yeah.
Why did you choose these materials? What were the properties that you're looking for in these materials, for example?
Before I was, for many years, I was doing injection molding just with flowable composites for the veneer of teeth. And I would have to layer. I would have a palatal, conventional composite for my palatal surface and an opaque composite for my core. And then I would layer with injectable to get my veneer from a model, from a wax up. But that took time, and ultimately I wanted to do more cases with less time. So when I discovered the GC injection molding kit, it was a major game changer in my practice because I could do multiple units in a shorter amount of time. And I do see a lot of tooth wear cases and aesthetic rehabilitations. So especially in the aesthetic zone, and I can use it in the anterior zone, in the posterior zone. So it was a game changer for me to have one kit for everything.
I see. And something about injection molding is like case selection is also quite important, right?
Yes,
When you
is.
talked about tooth wear, for example, you talked about like we have to know the reasons behind it and actually go over what's the reason behind the tooth wear that is happening. Make sure that the underlying reasons are dealt with first, because you're always going to have some complications if you don't treat
Very
them.
true.
Right? Tooth wear, for example, if a patient has a lot of bruxism, for example, how do you think case selection should be, or like material selection should be in these specific cases?
You have to be very careful with bruxism and grinding and parafunction in general, because you don't just have bruxism, you could have clenching as well.
Yeah.
So any parafunction is going to put the tooth on forces that it doesn't like. Compressive forces, composite, ceramic, they do well with. But when it comes to non-axial loads, the composite and ceramic end up fracturing. Even the natural tooth struggles. So we have to be very careful of these external forces that the tooth is exposed to. But if we can manage the condition Like, for example, now studies are showing that with bruxism, if we prescribe a hard stabilization splint that is worn intermittently, 1 week yes, 1 week no, that can help disrupt the habit. So you just have to wear it intermittently, not all the time. Also, sometimes when you're going to correct an occlusal problem, it can reduce grinding, because sometimes a patient grinds because the brain is trying to correct a malocclusion. That happens at night. So giving a patient a guard that gives you an ideal occlusion could help the patient sleep better, the muscles relax more, and the stabilization splint in itself, the hard splints, they have a negative feedback effect on the muscles of mastication. So automatically, you get relaxation of those muscles. Unlike a simple guard that is a soft guard, that doesn't do that. You remain grinding and clenching to the same force.
I see. As a point that you would want people to have always in their head, like if you're giving a lecture or if you're giving a hands-on seminar, what would you say a takeaway point that you always want people to have?
I think a takeaway point that I have given to all my students and colleagues is let's try give priority to preserving the underlying tooth versus preserving the restoration. Having that protecting the tooth underneath should be more important than how strong your restoration is, because ultimately it's what's under the tooth, under the restoration is the tooth, that there is the restorative cycle. The more we damage teeth, the less we're going to have to work with in many years.
Yeah.
And you want your patients with you for life, so...
Yeah, exactly. And the more, I don't know, the more extensive your treatments are, the more problems that you're just going to have in the future.
That's
Fixing
exactly
those
it.
is going to be a lot more difficult later.
Complete. And if you hack away at teeth, these teeth are going to end up needing root canals. Why?
Yeah.
They don't need all that. So
Yeah. Well, anyways, thank you very much, Dr. Ann
thank
Meli.
you for having me.
Thank you for being on the podcast.
Thank you.
And we'll see you again soon, hopefully.
For sure.
Thank you. Appreciate you.
Thank you.